they acknowledge that there are shortcomings in this definition. The shortcomings in this definition cannot explain phenomenon like phantom pain phenomenon. It cannot explain it. But they are working towards that since 1970s until recently in 2001, when Melzack launched the neurosignature neuromatrix theory, which partially almost explain, the phantom limb phenomena. So we are hoping there is an update on that. Look at this this is a painting exhibited in one of the most famous museums in Germany. It really attracted my attention. This is a painting for Professor Philip, who was a general surgeon during the 16th century, got vascular disease in his limb, and it has to be amputated. Having the privilege of, in the 16th or 17th century, you have one surgeon doing everything. Having a privilege to be a senior, he decided to preserve his amputated leg in a preservative water or solution, So every time he feel the pain in the amputated limb or in his toes on the left leg, which is amputated, he would take that leg or that amputated limb, put it on the table, try to dissect to find where the pain is. So he's the first one to start exploring that there is actually phantom pain. They were not sure. There is in the written literature, they wrote about the story, but at that time, there was no analysis. Why would Prof. Philip do that? But with advanced knowledge of recent days, I would think in person, he was doing this because it is part of coping with his pain. The fact that he take his leg and pinch it or try to dissect to see where the pain coming from, he found a way to cope with his pain, try to understand it, and that would give him a relief. This is my analysis to that painting. I think it is, but most likely. That's why those days when we want to try this kind of pain, we actually develop coping strategy for patients, change of thoughts. We try to advise them how they view their physical body, unlike what it is presented in their mind as a complete figure. We try to build coping strategy for amputees with phantom pain to explain to them how they view their physical body, the way their neurosignature in the brain. Because in the brain for amputee, they are a complete person, no amputation. And that's exactly, I think, what was going on in Philip's thoughts. So, pain classification. There is always a confusion between classification and diagnosis. You are walking in the corridor in surgical ward and as an anesthetist, and you met by the surgical fellow or consultant and tell you, can you help me in managing Mr. Paul's pain? You say, what kind of pain? Oh, he have acute pain or he have a chronic pain. This is a diagnosis for most of people, but let me introduce you for the first time how you differentiate between both. So we classified by pain as acute or chronic, malignant or non-malignant. So you could be having a patient present to you with an acute malignant or acute non-malignant, chronic malignant, or chronic non-malignant. This is a classification. Actually, the purpose of it is just about the time or duration. Because if you know this is acute, there is different line of diagnostic strategy. If the patient having chronic pain, your history will take different dimension and different classification. So what is acute pain? Acute pain generally viewed as biological, meaningful, useful, and time-limited experience. It's usually caused by identifiable stimuli. You can see there is a tissue injury, there is a fracture, short-lived, and it resolved when the tissue injury healed. As a result of effective treatment, the pain and associated symptoms like redness, edema, swelling will be disappear within days, maximum 2 to 3 weeks. But please keep in mind, there are two important things. Improper therapy during the acute stage of injury can cause the acute pain to change to chronic. And now it is a big thing. There's a lot of research on that many chronic conditions have come as a result of acute conditions, specifically post-surgical. So there is a lot of research even done at Aga Khan, like post-mastectomy chronic pain. We take it easy or for granted this patient going for mastectomy, but she ended up getting rid of the mass or the tumor, completely healthy, but rest of her life is torture due to chronic neurology after that. And simply because we have not managed her pain during and post the operative time. Why we couldn't manage her pain? Either lack of knowledge or we have the knowledge, but we did not do proper diagnosis. Again, the question comes, it is just post-operative pain. Do I need diagnosis? Yes, you do need diagnosis because you can't orchestrate your treatment plan without diagnosis. We are coming to that. And sometimes you have all the knowledge. You use all the precautions for managing the patient's acute pain. Despite everything, the pain is still changed to chronic. And that the mechanism, neurobiological mechanism under that is very complex, is beyond this presentation. But chronic pain can come as a result of unmanaged, and some proportion, even you manage acute pain, it can change to that. Chronic pain, in the other hand, is completely different game, completely. Even the setup diagnosis is different. Arbitrary defined as pain lasts more than 6 months. You will read that, and please remember, don't take 6 months as your landmark, because once at 3 months, 2 to 3 months, if you are managing acute pain properly and you see that the patient is still struggling, you need to know it is heading to chronicity. So you need to do something very urgent about it. Unlike acute pain, chronic pain usually associated with intense physical suffering, severely affected the patient's quality of life and their family, and its strong association with depression and anxiety and other psychosocial factors. Most of chronic pain patients have repeat consultation, repeat intervention. The consequences of inadequate, unsuccessful treatment of chronic pain can result or associated with poor physical, psychological health. Chronic pain also can result or often result to loss of job and income, experience of depression, which can develop into chronic depression and anxiety and stress. And recent studies have shown that actually uncontrolled pain can decrease the life expectancy of a patient. So it can go that far. The other important thing, these are consequences, can build up and accumulate over time. So when you are confronted with the patient with a chronic pain, the first thing you ask the patient presenting complaint where the pain is. I have neck pain or back pain. How long? 10 years. My interview go different direction if I have 10 years of chronic pain than 1 year or 2 years of chronic pain, because I would know I need to ask about what we refer to cumulative effect or consequences of a chronic pain. So the pain remain intractable all these years, obviously meaning there is unconfirmed diagnosis, repeated treatment failure. This is what you see with the chronic pain patients, multiple referral to several consultants, and obviously that would increase the cost, which become an additional factor in the psychosocial element or component of pain perception. So you can see the difference between acute and chronic pain, but the question comes to you. The pathway is the same. Peripheral stimulation, dorsal root ganglia, spinal cord, go to the brain, higher center, you have descending mechanism. But why chronic pain is more complex than acute pain? We need to focus on the neurobiology, which is you are going to have an overview during the lecture by Dr. Yonga. However, chronic pain may change the structure of the brain, structural changes in pain matrix, meaning dysfunctional of antinociception, not necessarily neural destruction. That's why you have to act quickly in managing those patients. Should be reversible if your diagnosis is right. If you conclude a diagnosis and conclude a treatment, a plan. There is this study of series in Newman, which is very interesting. Explore or explain what I've been saying. They have a study on patients, big population on patients with back injuries. They found 80 to 90% of workers return to work in the first 2 weeks. However, there is 5 to 15% of this population end up on wheelchairs. They went back to the demographic profile of those patients. They look at the MRI, they look at the surgical intervention. They found the two groups is identical. The only difference between somebody have returned to work and somebody end up actually on a wheelchair due to chronic pain is the psychosocial component of this group of people. That is the only difference. So that's why they conclude that disability is more difficult to treat once it has continued beyond 6 months. And therefore, when you detect that patient is struggling with symptoms after your management, a prompt reassessment, pain diagnosis, and intervention is very important for those patients. Diagnosis. We have just done a classification. So what is diagnosis? How I make a diagnosis for my pain, acute, subacute, or chronic. So whether your pain is acute, chronic, malignant, or non-malignant, that's a classification. Your diagnosis may be nociceptive pain, or in neuropathic pain, or mixed nociceptive and neuropathic, or psychogenic pain, or all the above. So what I'm going to do, how I do my diagnosis. After patient assessment, if the pain nociceptive, your treatment chart will be anti-nociceptive. If the patient have nociceptive and neuropathic, let me come to cases that you deal with. Let me not go to chronic pain. For example, post thoracotomy. You have just done thoracotomy to the patient, they fiddle with the ribs, or patient come with multiple trauma and fractured ribs. Soft tissue injury, bones, is nociceptive pain. But fractured rib is a neuropathic pain. So you go and you put your patient in the best treatment chart and you make sure you have done a great job. But patients keep screaming of pain because you have not added a neuropathic medication to the chart. Psychogenic, you have to address patients' fear, worries, and other psychosocial factors to treat them. Again, I go to postoperative pain. Dr. Bal have a patient, just a DNC. From her history show that the patient's cervix was actually open, they were just cleaning up. Go to theater, DNC cleared, wheel her to recovery, she had myomectomy. She went back to theater, very busy, inducing a difficult patient. Recovery nurse keep coming back and forth. Dr. Bal, the patient screaming of pain. The patient screaming of pain. The patient screaming of pain. Cervix was open. We clean up. We put the patient on paracetamol drip, maybe NSAIDs, maybe even opioids. So here, instead of saying, hold on, I'll go and assess the patient, the first thing she might say, okay, go give her pethidine. This is what everybody says. You are busy with another case. And that's the truth. But the scenario this patient is screaming, it can't be pain because you know the cervix is open, there is no great nociceptors, you have given her paracetamol and NSAID, and maybe even a tramadol. But the patient is screaming for something else. Patient had a DNC, she lost her pregnancy, and most likely those patients with the repeated IVF, during the recovery time, what happened? All of you, most of you is anesthetist. Recovery time, your limbic wake up in the brain before the frontal. The frontal is still asleep. So the frontal, which control the limbic when you are awake, if you want to say something silly, your frontal say, don't. It's not nice. You will be embarrassed. So your limbic shy off. Now, when you wake up from anesthesia, that recovery area, your limbic is very free to say, wow, the frontal is still sleeping. Now the patient inner feeling is going to come up out explosively because the frontal is asleep. So she starts screaming. She have some awareness, and if she asks why, she can't say because I lost the child. She will just say I am in pain. So for a patient like that, if you give opioids, what will happen? You actually put the frontal more to sleep and your limbic more awake, and she will keep screaming until she gets respiratory arrest of overdosing. So what you do, small dose of midazolam, any anxiolytic drug, just to calm the limbic system, and your patient will be very happy. And you buy time until your frontal awake, and she starts using her coping strategy that she have it preoperatively. So this is the value when you make a diagnosis. When I have a patient, is the pain nociceptive? Is it neuropathic? Is it together? Is there a psychosocial element? Orchestrate your treatment chart that fit with your diagnosis. It's getting a little bit complex. You are going to do round and see 10 patients, and for every patient, Dr. Thikra said, nociceptive and neuropathic psycho, this. There is an easier way of dealing with. Is a model. Keep in your mind the biopsychosocial model in pain, assessment, diagnosis, and treatment. So any patient you have, postoperative, acute, or chronic, post-surgical, think about the biological element, which is nociceptive and neuropathic pain, psychological element, there is stress and anxiety and depression, social environment, which is to deal with the environment, social component, which to deal with the environment of the patient. So the biopsychosocial model suggests that pain is a complex experience, as we all know, influenced by combination of biological, psychological, and social factors. It recognizes the pain is not solely determined by tissue damage. So don't keep giving the patient medication that, oh, it is due to surgery. There are other emotions or behavior contribute to how the patient perceive pain and report pain to you. I come in the morning and ask the patient, okay, after doing intervention, how is your pain? Are you better? Yes. So your pain was 10 out of 10. What is it today? 7. She's sitting comfortably. She walked to the washroom. She did all what she could not do the day before. Now, 7 is what she perceived. But I need to analyze to see is 7 means 7. Because not that to satisfy myself and to say, wow, I made a good job, is to start reducing the patient's medication. Because if you keep taking that report, your medication chart keep escalating for nothing with complications. So how the patient report also pain, not necessarily how they perceive it. Sometimes they don't understand. So patient report and how they perceive and related to actual nociception, it is not necessarily correct if you take only verbal report. So that's why when I look at you, I do the interview, take your verbal report, but I'm observing your pain behavior. I'm sitting for 40 minutes interview, observing how you move, how you stand, how you walk, examination add-on, and see whether your report of pain corresponds to your actual underlying cause of pain or your examination. That correspondence give me the net effect or the net results, how I'm going to manage you. So This is the onion skin model, which developed by Loiza, one of our other pioneers who worked very, very closely with Melzak and Waltz. He developed onion skin model. In this model, just remember, everybody now I made it easy for you because everybody love onions and you have onion at home. So the onion skin model concept is, here is a tissue damage. Any tissue damage results to pain sensation, ouch. When you have a pain sensation, always you have thoughts in your mind. If the pain in the right iliac fossa, even if it is for a moment, you say, oh my God, do I have appendicitis? Do I have this? Am I going to die? Am I going to the hospital? So it is instant. It is in microsecond, your mind is still working. Change of thoughts, there are emotions. All these layers made the patient present to you not smiling, suffering with your diagnosis, and I'm going to optimize on medication. Please go take them regularly, take the right dose, and I want to see you next week. Then leave. In 4 days, the patient comes back with the daughter. I'm sitting, she walked in. The way she walked just from the door to my desk, which is about 5 meters, I can see this is not a musculoskeletal pain. You know, it's that everything, all the pain in her face, all the suffering in her face, that's not a musculoskeletal. I said, what's up? She said, all what you gave me, my pain is getting just worse. My back is killing me. The pain only on the lower back. So now, perfect diagnosis, comprehensive optimized pharmacological treatment, patient come with no response. I go to system review. I start asking her all those questions you see, central nervous system, cardiovascular. I reach the GIT. I said, your appetite? Yeah, lately because of the pain and medication, always there is because my appetite is not as good. Do you had any blood passing with your stool? Yes, actually I have it for the last 2 years, but a smaller quantity. And she was with the GIT team, yeah? So what's up? Yeah, I have a hemorrhoid and a fissure. And they said this is because of that, which is true. She have hemorrhoid and fissure. I said, okay, now remain only one question. When you pass the stool, do you feel pain? She said, no, it's not painful. It just little blood come from time to time. All what I did is one thing. CT scan of the pelvic and the abdomen with contrast. I said, go do it and come. The result is advanced stage of colon cancer, which is already metastasized because all her lymph nodes in the pelvis were lightening. All her team sent her back to the team. So this is the value of system review when you see the patient is not responding to medication. Circumstances of onsets. It is responsible and perhaps attractive to explore how and why the patient pain started. Usually we leave it at the end of the assessment. It's very important because also when you are having this interview, you ask the patient and observe their behavior. You can actually pick the group of patients which have legislation issue and work-related injury. You find them now by the end of the interview, after 40 minutes, he's thinking you are a very nice doctor. You ask him so many questions. He's your friend. So he starts telling you, no, I fell at work. But how could you trigger that? How did you fall at work? You mean the chairs were not okay? Yeah. Our bosses don't care about how we said. They don't get us that. Now, from that conversation, you know that this patient have come with that package. It is work-related injury legislation. Again, this group of patients, we treat them completely differently. Previous therapy is very important to ask the patient what medication he have received, not only to ask them, okay, what medication? He'll tell you, okay, I took Myospaz, Orphan, paracetamol, gabapentin. That's not enough. Ask them about the doses, frequency, a duration of those medication. Many patients take all the medication you are going to prescribe, but it failed to achieve the reason simple because they were not in adequate doses or adequate combination of medication. Then later, which is the last at the end of your review, you review the patient's laboratory, radiological films, whatever the patient has, see if you need to order some new investigation for the patient. Then at the end, you do your physical, neurological, neurophysiological examination for the patient, and the last information about their environment, which I have just mentioned, to rule out if there is any legislation or work compensation. So in history, there are three major concerns: if there is evidence of systemic disease, evidence of a neurological disease, and is there a social or psychological stress which contribute to patients reported during the interview. Now, as I mentioned earlier, when we do the system review, we try to rule out the red flag. It could be general cancer or infection or fracture. This is what the red flag. We go categorically for every patient, but only if needed. Or if the patient report do not correspond to their underlying cause of pain, perhaps you have a yellow flag, which is the belief that pain is harmful or severely disabling. Fear avoidance behavior contribute or it has a great contribution for patients' lack of movement and disability. Many patients simply they end up from walking with two walking stick to wheelchair simply because of fear avoidance behavior. We have to measure that. Social withdrawal and low mood expectation that passive treatment will help. So in examination, as I say, we do musculoskeletal and neurological exam. I'm just giving you little bit tips about musculoskeletal pain. Of course, patient with headache, you don't go for this kind of examination. We examine the patient during walking, standing, sitting, and supine position. If the case is complex, patient on a wheelchair or two-crutcher, we try to take a video. We take the patient from the clinic to the adaptive program and take a video for all their activity before we start the treatment, during the treatment, and after the treatment, we take videos of their activities. For example, how the patient walk. We observe their gaits or we take video. We measure the length of the strides, arm swing. Many patients with back pain, they have short stride and they have a frozen shoulder because they don't want to move their lower back. All those, we mark them in the drawing. In many patients, we take a video and we assess some of the things we need actually to draw and measure. Standing and posture, just to check for kyphosis, hyperlordosis, or scoliosis. That's towards the end of consultation. We ask the patient to unaddress, and then we take photo, and we have it in the drawing how the spine alignment. Range of motion is measured during examination with lumbar flexion, extension, and side rotation. And palpation, for example, you can see in this picture, we palpate the paraspinal muscle, and we assess the spinal processes. For example, patient with scoliosis, you don't see it just like that, but when you palpate, you find there is deviation of the alignment of spinal processes, which shows you that there's scoliosis. Urge yourself for an X-ray of the spine. Assessment measure, which is used very commonly, perhaps one of them, which is the VAS in your hospitals, either self-report or a questionnaire. VAS scores or McGill pain questionnaire. McGill have more advantage than the VAS because it has little bit, not comprehensive, multidimensional assessment or measure three components, which include not only the sensory component, but the intensity and cognitive evaluation. But my message to you, all those measures are subjective to bias. Why? Again, it is beyond the discussion of this presentation, but this is not something to rely on specifically in chronic pain patients. Why? Because we have agreed that pain is multidimensional, and we need many instruments to assess the pain, severity, quality, mood, degree of interference, or activity of daily living. You need to measure the patient's behavior and cognition, and that cannot be measured with VAS or McGill pain questionnaire. So after comprehensive assessment, you will be able, at least in 90% to 95% of patients, to conclude a diagnosis or impression. And based on your conclusion of diagnosis and impression, you can conclude a treatment plan. In a chronic pain, specifically musculoskeletal pain, your conclusive treatment plan, always tell the patient this is diagnostic and therapeutic. As this lady I have present, the patient might come back and say nothing works, so your treatment become actually diagnostic. At the end of the day, and as Dr. Bal have mentioned earlier, our practice at the pain management unit, we need to pay attention equally, not only to have the patient happy and pain-free, but we need to improve function. It's easy said than done, because if you improve pain and patients say, oh, you are an angel, so how was your day? No, I didn't move. I was lying on my back because I'm scared to move. You have done nothing. You should pay attention to improve activity as much as to relieve pain. Thank you.
Thank you very much, Dr. Thikra. We're going to, so